it. Yeah, perfect. Thank you. Okay, so this will be recorded so that we can post it on our website and people can go back and watch it and etc. But I'd like to welcome everybody to the Bench with Bedside webinar series, a very special day today. It is a keynote seminar by a very special person, personally to me, but to the world of breast cancer around the world, Dr. Joyce O'Shaughnessy, who is the Celebrating Women Chair in Breast Cancer Research, Texas Oncology. And I can't talk enough about Dr. Shaughnessy, and I will try to sum it up in 2 minutes. Give you a little bit of feedback, but just as a way of reminder, this is a webinar series for the Bench with Bedside initiative. I'm Badur Salhi. I'm an associate professor at the University of Southern California, the Norris Comprehensive Cancer Center. And as I said, today's keynote speaker in sort of honor of Breast Cancer Awareness Month is Dr. Joyce O'Shaughnessy, who is a world leader on breast cancer prevention and treatment, and she is the co-chair of breast cancer research.
Oh, you do?
The chair of breast cancer prevention research at Baylor Sammons Cancer Center, and also for the US Oncology Network. And she's also a member of the Scientific Advisory Board for US Oncology Research Network. She's had so many awards, more than I can possibly have time to list here. She's a member and active participant of the American Association for Cancer Research, the American Society of Clinical Oncology, the American Medical Women's Association, the American Medical Association, and the American College of Physicians, and the list goes on. She has over 400 papers. Most people are lucky to get a New England Journal of Medicine paper. Dr. Shaughnessy has several. She's published many seminal work in breast cancer and breast cancer treatment. She is a humanitarian. She's a great physician, and she's also a scientist and understands breast cancer, I think, more than anybody that I know. And she is my go-to person, and she's so kind to be always available to chat and discuss ideas. We've worked together and are working together on various things. And I just want you to get started, Joyce. So with that, I'd like to say again, thank you for being here. And I'm going to pass the baton on to you to give your seminar. Thank you again.
Thank you, Badur. So good to be here with you. Yes, I love Badur, have for many years, and it's fabulous work, and it makes it look easy. Badur just very smooth. Everything's easy. Just comes. All of her hard work really pays off. I'm so excited about the work you're doing now, Badur, which I'll mention here in a little bit. So very happy to join everybody here today and just talk about kind of really a very important evolving topic in breast cancer management. I know many people joining have either had breast cancer themselves, or a family member or a friend has had breast cancer. It's just so very common. And this is a really very much of a cutting edge topic that it is really going to completely change how we take care of women and men with breast cancer. So it's a pleasure to talk to you about that. Where are we today? Where are we going? I'm going to share with you a trial that I'll be opening through our Baylor University Medical Center in Dallas. And it may apply to some of you or some of your family members or friends. It's any day now it'll be opening, so it's not open yet, but I will share that with you. That'll be the last part of my talk. I want to leave time for questions and answers. And if we don't get to everything, I'm happy to provide input by email so we can get to everybody's questions. So I'm going to be focusing on early detection and treatment of microscopic disease in women who present or who have been treated for in the past with early stage breast cancer. So let's go forward here. So, all of my women and men as well who have had or have early stage breast cancer ask me the following questions when I first meet them. Has my cancer spread? How can we tell? And then if I need treatment for my whole body, I've had my surgery for the breast, I may have radiation, but if I need chemotherapy or hormone therapy to treat microscopic disease that may have spread somewhere in the body, how do I know it's working? How do we know when we're done? And then when I'm finished that or finish the chemo. Now I'm on my hormone therapy if the cancer is estrogen receptor positive, because if it's not, hormone therapy is not needed. But how do I know that I'm cancer free? Can I say that I'm cancer free? How will I be monitored for recurrence? How will I know I'm okay? And then if we find, if we're doing scans and looking for the first signs, early recurrence, if we catch it early on bone scans, CT scans, and we treat it early at the earliest time, will I live longer having caught it early? So these are, of course, the standard question everybody wants to know, what's the big picture here with the breast cancer? So let's have a look at this whole concept of minimal residual disease, MRD. It stands for, we'll be talking about MRD here. And so over on the left, we see the depiction of the primary breast cancer, the breast cancer in the breast. And before it's found, long before it's found on mammogram or one can feel it, during that time, cancer cells can break off from that original breast cancer, and as shown here, can travel through the bloodstream in the picture in the middle, and it can get to the bone down below. It can get into the bone marrow. It can get into the bone as DTC, disseminated tumor cells. And then the little cells, the cells from the breast cancer, they can actually take up residence there. They can survive there. Many of them, the vast majority don't. They're destroyed by the immune system, but some can take root. They can actually take hold in the bone or in the lung or in the liver, for example, and they're there. Now you've got microscopic disease. It's minimal, microscopic residual disease, and no scan can see it. No PET scan. We're talking cells, okay? So we don't have a way of knowing whether it's there or not today, but that those cells that have metastasized, little cells, when they're growing, when they're dividing, some of them die, and they actually will kind of blow apart. They're dying, they're blowing apart, and they kind of spill their insides, and that they can release DNA, the DNA that's in the nucleus, the DNA that's the blueprint that have the cells divide. And so you can find it only lasts minutes to an hour in the bloodstream. So it's cleared out by the body fast. I mean, it's harmless. The body clears it out fast. But if you do blood test, you can actually, you can detect it. You can see the tumor DNA different than our own normal DNA. In our normal cells, you can find the DNA in the bloodstream. And so that could be a really important diagnostic test to find the earliest microscopic signs of breast cancer. So that's what we mean by ctDNA, circulating in the bloodstream, tumor, not normal, but tumor DNA. And that's the DNA, of course, the blueprint in the center of the cell that makes the cell divide and survive. So that's what we mean by ctDNA. It's a blood test to look at the most microscopic of breast cancer in the body.
She wanted me to take it. She said no.
Oh, could somebody go ahead and just mute their line? That would be great. If you could just go ahead and mute, that'd be super. So this curve, I'd like to describe this curve to you because I'm going to show you a whole bunch of curves that look like this. And down at the bottom of this curve where it says time in months, that is time from 0 time point to 25 months, 50 months, et cetera. So this is going out a lot of years here, more than 10 years. And then on the over on the left, the vertical line where it says survival probability, that's actually the percentage of women who remain cancer-free. They've not recurred. So you see over time 0 on the far left, it's 100%, 1.00. That's 100% of the women are cancer-free. They've not recurred. These are women with stage 2 and 3 breast cancer, where the cancer is more than 2 centimeters in size in the breast, and there may be lymph nodes involved. So a little bit, more breast cancer than stage 1, where the cancer is small and node negative. Stage 2, 3 is a little bit larger breast cancer. But over time, you see in the red is stage 2 and in the blue is stage 3. Over time, the percentage of women who remain cancer-free goes down, down, down. And this is with our best therapies today. This is with chemotherapy, Herceptin, hormonal therapy, immune therapy for triple negative breast cancer. This is with our best therapies that we have. We still have women, like in the red bar, for example, the red graph, by 50% of the women have had recurrence of their breast cancer at around 13, 14 years. And in the blue, 50% of women have had recurrence of their breast cancer by about 7 years or so. So we're still having far, far too many recurrences of breast cancer. And really the question is, if we knew that someone still had tumor cells, microscopic tumor cells in their body, if we could detect it with a blood test, with the circulating tumor DNA, could we give those women additional therapy? But if they're clear, if the blood is clear on multiple tests over time, but there's no sign of the microscopic disease, we do not treat those women with additional therapy, or maybe at some point we even stop treating those women. Would they do okay? And if we found the tumor early on the blood test via tumor DNA and we treated them, would they have improved outcomes? So that's really the important question here. So this shows again this concept of the circulating tumor DNA, and you can just see over on the left, that's a blood vessel. We can see the CTCs; those are circulating tumor cells. But what we're looking for is the squiggly red and blue DNA. That's just plain DNA from the nucleus that actually is the blueprint for the cancer cell, and it just is in the bloodstream because the body's clearing it out. It's getting rid of it. And what happens is that each of our tumors that are taken out of our breast, they all contain a unique portfolio of mutations, of changes in the DNA. Every tumor is different, and you can go to that initial tumor and it can be sequenced. All the mutations can be categorized in that tumor in the breast, and then very specific mutations, 16 mutations, 100 mutations, 200 mutations can actually be identified for that woman's individual cancer. And then an assay can be made to then check that woman's blood, check her blood for those specific mutations that we know are in her cancer. Very, very individualized, very personalized blood test looking for mutations from her cancer in her bloodstream. And then if we find them, that's very concerning. We know that there's still evidence of microscopic breast cancer in the body, though we cannot see it on any scan, any PET scan at all. But we know it is there. Now, the thing is, as you can imagine, over on the right, the test tube on the right, we don't see any of the little red DNAs. And then as we move to the left, we see more and more molecules of the red DNA. And so sometimes in the bloodstream, there'll be a lot of the DNA from the tumor, and it's easier to find it. But as we go to the right and we get down to one molecule, just one DNA molecule in a tube of blood, that is very difficult to find. It's truly, truly like the needle in the haystack, because you know what the blue DNA is your normal DNA. We have a lot of normal DNA in our bloodstream as well. So finding the tumor DNA in the midst of the normal DNA is really a huge challenge. And if the tests are not sensitive enough, you're going to miss it. You're going to say to a woman, you're fine. We can't find the tumor DNA. You're good. And she's not good because it's just not sensitive enough to find it. On the other hand, we need it to be very, very specific. We can't be given her wrong information. We can't say, oh gosh, we found the tumor DNA in your bloodstream, and that turns out to be wrong. It actually was normal DNA. A mistake was made. So it wasn't specific enough. So we need sensitivity. We need to find it and not miss it because it's so tiny. But if we say it's tumor DNA, it's got to be tumor DNA and not regular normal DNA. So this is the big challenge. This is the technical challenge. And this is what Baylor has been working on, is manufacturing and making and producing tests for this tumor DNA that's extremely, extremely sensitive. So it turns out that there's two different ways to look for tumor DNA in the blood. One is what I already mentioned, is you go back to the original breast cancer that's over in the pathology department. It's stored over there in wax blocks, and you analyze that tumor tissue for the mutations. You pick out very specific mutations that really represent that woman's individual breast cancer. And then there is an assay made, a test is made, so that when blood is drawn from the woman, that those specific mutations can be identified in her blood if they're there. We call that tumor informed because it starts with the actual tumor tissue, and you're making a custom assay. You're customizing, looking for her tumor mutations in her bloodstream. So that's called tumor informed. And then there's another way to go about it, and that is not to go to her original breast cancer, not to go to the woman's breast cancer, but rather go to a set of mutations that's known to be abnormal in breast and in a whole bunch of different breast cancers. You could take 500, 1,000 breast cancers, look at all the mutations and pick out a few hundred of them, for example, that really are representative among breast cancers in general across the board, a spectrum of mutations, and then look for those in a woman's bloodstream. And so I'll just mention here that what Bauder's been doing with her research is she's been actually looking at metastatic breast cancer. So breast cancers that by definition were, dangerous breast cancers. The cells were indeed able to travel from the original breast cancer in the breast and spread someplace in the body. And eventually it just kept growing and it turned into a metastasis. And so those cancers have mutations in them that enable that cancer to actually spread. And that's what you're interested in, because you're trying to find microscopic cancer cells that have spread. And so Bauder has looked specifically for mutations, and I'll show you a picture in a little bit. What specifically, she's been looking for mutations that are in metastasized breast cancer and has built an assay, built a platform to look for mutations in women with early breast cancer, but she's looking for genes that really show that this breast cancer can indeed metastasize. But it's not specifically for that woman's original breast cancer from her breast, but it's looking across the board at many, many hundreds to thousands of breast cancers, the kind that actually were able to metastasize. So that's a fixed panel of known mutations that you look for in the bloodstream. But the bottom line is, whether it's tumor informed or tumor agnostic, it means that you're looking still for tumor DNA, but a very specific number of DNA coming from the tumor in the woman's bloodstream. So let's look at this this cartoon here. Over on the left, the far left, you see it says levels of circulating tumor DNA. And down, if you go down way down the bottom left, that would be no tumor DNA. Way down the bottom, there's none. And then as you go up, the tumor DNA gets more and more. So that first hump, that first hill is actually when the cancer first presents in the woman's breast. Generally speaking, if you do a blood test at that time, you will find tumor DNA in the bloodstream. So you can find it because the tumor is still in the body. But then you see it says the word surgery in blue. Then if you then test the blood, the tumor DNA falls way, way, way down, either to nothing, which is really a good sign, or you can still find a little minimal. That's of concern. When the tumor itself is gone and you can still find some tumor DNA in the bloodstream, that's of concern, isn't it? That there's still some cancer in the body, but it's microscopic. And then here comes that second green hill, starting from the left, the second green hill, that's a relapse. That's a recurrence. When the microscopic DNA, the microscopic tumor cells keep dividing, they're getting bigger, and they are continuing to make DNA. You can find more and more in the bloodstream. And then at a certain point, there's enough cancer cells. And now if you do scans, you can actually find a metastasis in the liver or the bone or something. And then, of course, we treat that metastasis and the tumor DNA will go down if the treatment's effective, but you see it never goes to zero. Over on the far right, you see the tumor DNA going up and down those hills. It goes down when the cancer, the treatment for the metastatic disease is working, and then it goes up when it's no longer working and the cancer is growing, but you see it never goes down to zero. What we need to do in the center of this slide, we got to get this tumor DNA down to nothing. We got to clear it and we got to keep it clear. That's the goal. And we can use whether the DNA is there or not as a marker, as an indicator of whether the treatment for the early breast cancer has worked. Did it get rid of all the cancer in the body? Did it get rid of all the tumor DNA in the bloodstream? Kind of like a tumor marker, if you will, but this is specifically tumor DNA. So here's an example. This is a woman now, she's got a tumor in her breast. And over on the left, the mutation analysis is done of her breast cancer. In number 2 in the middle, they have found the specific mutations in her cancer. And indeed, before she has her surgery, over on the right, you see that graph and going up and down vertically from up from 1,000 down to 10. That's the amount of tumor DNA that's in the bloodstream. And time 0, T0, is when she's first diagnosed with the breast cancer. The green is when she's getting Taxol chemotherapy. The pink is when she's getting adriamycin cytoxan, the AC chemotherapy. And T3, time 3, is the time of surgery. Now, what you want to do, you want to see, as this woman is getting her chemo before surgery, pre-operatively, which is neoadjuvant chemo, and if you're monitoring that DNA, you want to see that DNA going down, down, down. That means the treatment is working. If the tumor DNA is going up, that particular chemo is not working. You see how powerful this is? We don't have a way of knowing this. We have no way of knowing right now whether our treatments are really killing off microscopic disease that may have spread. And so this is very, very powerful. What we hope to do is what's shown here. By the time this woman goes to surgery, that the tumor DNA in her bloodstream is down to 0. That's what we're really hoping for. That's a success. Now, if it's not, and it's going in the wrong direction, that means the therapy is not working and the microscopic disease in her body is growing, okay? So here's what a report looks like, just so you know. So there's a test. There's actually a few of these tests now commercially available, meaning we can just order them in the clinic. And one of them that's been around the longest is called Signatera. And if you look down sort of in the middle of the slide, it says over on the left, MTM per milliliter. That stands for mean tumor molecule. So actually the number of tumor DNA molecules in the woman's blood. So over January 30th, 2021, she's diagnosed with the breast cancer and her tumor DNA number is up around 50. Then over the next months, she's getting treated for the breast cancer. Down, down, down goes the tumor DNA. And by March 16th, 2021, there is a hollow circle. It's not filled in. That means it's gone. It can no longer be found. So you can actually quantitate in the bloodstream the amount of DNA in the bloodstream. And so this would be a success story right here. Now we want to see it over time, years and years and years, right? We want to see it stay 0. Now, if it starts going up, that's not a good sign. It means that there's still a microscopic disease there. That we couldn't detect it. We thought it was down to 0, but we couldn't detect it. It wasn't sensitive enough. And now over time, it's going up, which means the cancer is starting to grow microscopically in the body. And here's an example over on the left. Time 0 is again baseline. That's when the woman, this is a whole bunch of women from an actual clinical trial, whole bunch of ladies were just diagnosed with breast cancer. And you can see it goes from 0, 10, 100, 1,000 over on the far left. That's the amount of tumor DNA in the bloodstream when they were first diagnosed with the breast cancer. And then you see the number 60 in blue, 60 of the women when they just got their Taxol chemo before surgery. So preoperatively, their tumor DNA in the bloodstream went to 0, meaning the Taxol worked great. That's paclitaxel is Taxol. But then there's others like in the navy blue or the green or the pink that did not go to 0. You still see the numbers are up there. And then the 59 in the navy blue at the beginning of the AC. So at the very end of the Taxol, 59 ladies now, their blood cleared of the tumor DNA. So now they're down to 0 because the Taxol helped them. But then the green 25 ladies at the end of their AC chemotherapy, they went down to 0. Okay, so they're doing pretty well. But the ladies in the pink, that tumor DNA never went down. And you can see that's pretty much of a straight line over there. That's flat. That tumor DNA never cleared. That means the chemo didn't work for those patients. And if you look over on the right, so what we're looking at on the vertical line, DMFS, that's distant metastasis, free. What percentage of the women are free of metastasis? So they're starting at 100%, but in the green, if the tumor DNA has not cleared, by the time they go to surgery, if it's not cleared, you can see over time, you can see the horizontal line is the number of days. You can see by about 1,000 days, 3-4 years, almost half of the women now have developed a metastasis. Conversely, in the blue, on the blue curve, if the tumor DNA cleared, if it's negative while they were getting their chemotherapy and it cleared, those women stayed 100% of them in this particular study stayed free of recurrent cancer, free of metastasis. So this shows us how really very important it is. You've got to clear the tumor DNA. If you don't clear it, and this is very, very clear across multiple studies, if you don't clear it with a chemo, hormonal therapy, Herceptin, immune therapy, whatever the standard treatment is for the breast cancer, if you don't clear it, then the cancer can recur over time. It's a high chance of it recurring, not 100%, but a high chance that it's going to recur. If you clear it and it stays clear over time, there's a much less chance that that cancer is going to come back as a metastasis. This is just another study for, again, using the Signatera assay, looking for the tumor in the bloodstream. And this is when women have had their breast surgery. They have finished up their chemotherapy that they received before surgery. Now they went to surgery. So the cancer is now gone out of their breast. If you then get a blood test and look for tumor DNA, and you see the darker blue line that's going down from it starts at 1.0, that's 100% of women cancer-free by 50 months. So about 4 years after surgery, there's no women that are free of cancer. The cancer has come back over those 4 years in all of those women who had still cancer DNA in their blood after they got the chemo and after they had the surgery. They still had tumor DNA. It wasn't gotten rid of by the treatment. Those women, pretty much all of them in this particular study, had a recurrence of their breast cancer metastasis. Now, the lighter blue line on top tells an important story. If the women are clear on their tumor DNA, if they're clear, you can see they start off at 100% cancer-free, 100% of the ladies are cancer-free, but then unfortunately, some of those ladies are still recurring. You see how that curve is going down, and by about 50 months, about 25% of the women have had a recurrence because only 75% of them are recurrence relapse free. So this is an important point. Why is it that the women are still having a recurrence, even though the blood test says it's clear? There's no tumor DNA that can be found. And the reason is the assay, the test, is not sensitive enough. It's missing it. It's really there. It is a false negative. And this is the problem. This is why the Signatera, quite honestly, is not really ready for prime time in clinic for early breast cancer, because quite honestly, it's not accurate enough. If you find it, we know it's very, very concerning. We know that woman is at high risk for recurrence, as we see in the navy blue line. But if everything's clear, they're still here over 4 years, a 25% chance of recurrence. So we cannot say to somebody, you're in the clear, because the test is not sensitive enough to find minuscule, minor, so tiny amounts of DNA in the blood. That's a very, very important point about where we are today. Now, this just tells us that what the story I'm telling you about, if you've got the tumor DNA, it's bad, high risk for recurrence. If you don't have the tumor DNA in the bloodstream, it's much, much better. This is true whether on the left, the cancer from the CHIRP trial is hormone receptor positive, HER2 negative, in the middle, triple negative, and on the right, all subtypes. And the other subtype, the main one, is HER2 positive. So this is true if tumor DNA is found, regardless of what kind of cancer it is, it really says there's a super duper, super high risk of recurrence within a few years, unfortunately. But the blue line on the top here, if the tumor DNA is clear in the blood, you cannot find it, it's not a guarantee. It's not a guarantee at all that there isn't going to be a recurrence, but you can see, of course, it's much, much less chance of recurrence. So I just wanted to show you, this is a modern day important clinical trial. You may have heard of this pill for breast cancer, for early breast cancer, called Verzenio. It's a pill taken for 2 years after breast cancer surgery. It kills cancer cells that are hormone receptor positive by stopping the cell division. It stops cell division and kills the cancer cell. It's a standard drug now for patients with node positive early breast cancer that's hormone receptor positive. In this clinical trial, the Monarch E trial that led to FDA approval of the Verzenio pill, they monitored DNA in the patient's bloodstream. And if you look at the top right, now we're looking again on the vertical axis, we're looking at the percentage of ladies who have developed a metastasis. So over at the top, it says 100% are cancer-free. That's 100% don't have metastasis. So they start their Verzenio pill, right? Now, if they're in the red curve, if you find tumor DNA in those patients when they're just starting their Verzenio and it does not clear, here they are taking their hormonal therapy, they're taking their Verzenio, and you're testing the blood, looking for mutations in their cancer. If that does not clear, you can see that over 3-4 years, about 2/3 of ladies will have a recurrence. That red line going down means fewer and fewer women are free of metastasis. In the blue line up top, those are the women who do not have DNA you can find in the bloodstream. So this is good. It looks like they're clear. You can't find the tumor DNA, right? This is good, taking their Verzenio, but you see, unfortunately, it's not a guarantee. If no one's cancer came back, that would be a straight line. There'd be the blue line would not go down at all. It'd be straight across. But you see, over 3-4 years, about 25% of these women are still developing a recurrence of their breast cancer because the blood test was not accurate enough to pick up tiny amounts of DNA. So you can see it's a whole lot better to not be able to find any tumor DNA in the bloodstream, but it's not a guarantee that you're clear. Conversely, in the red, if you do find tumor DNA in the bloodstream, it's a very, very serious sign that the woman's at very, very high risk of recurrence. So there's so many studies now to show us this, that being clear is a whole lot better, but it's not a guarantee of being clear of tumor in the body because the blood tests are not accurate quite enough. So let me share one of my patients with you. And this is one of the uses for the tumor DNA blood tests in the clinic today. I have a 52-year-old woman. She's postmenopausal. She underwent a mastectomy. It was a 4-centimeter cancer. Grade 3 means it was faster growing aggressive cancer. It was ductal, and she had 2 positive lymph nodes in the axilla. It was estrogen receptor positive, HER2 negative, fast growing, a high proliferation rate. She received chemotherapy with the standard AC Taxol chemo. Then she went on to the hormonal therapy, anastrozole. She had radiation therapy, but she really didn't want to take the Verzenio. She was sick of drugs. She had her chemotherapy. She was taking the hormonal therapy. She said, I really don't want to take Verzenio. I know it can cause diarrhea. It can make me tired. I don't want to take it. Will you do the blood test for me? Would you do the tumor DNA blood test for me and see if I'm clear? If I'm clear, I'm not going to take the Verzenio. If tumor DNA shows up in my bloodstream, I'll take it. And I'm like, oh my gosh, that's not how we want to do it. We want to give you the Verzenio because that's how it was done in the clinical trial, because the blood tests are not perfect. It can be clear, but you can still have tumor, but it's not standard to do this. It's not standard because you can miss things. You can miss it. But she wasn't going to take the Verzenio otherwise. And now there's a competitor of Verzenio called Kisqali, another pill that does the same thing. So there's two of them now. But we decided to do that. We decided to monitor her by getting blood tests each time she came in the clinic to look for tumor DNA. So it's not standard, but she said she'd be willing to take the Verzenio if the blood test showed indeed there was still tumor in her body, microscopic with tumor DNA in the bloodstream here. But the big limitation, the reason we're not doing this every single day in clinic right now is because in the smaller print here, we don't have evidence from clinical trials that if we find the tumor DNA in a patient who's already had everything, she's had surgery, radiation, chemo if she needed chemo, hormone therapy if the cancer is estrogen receptor positive, immune therapy if the cancer is triple negative, Verzenio or Kisqali if it's hormone receptor positive. She's already had everything. She's had everything we know to give her that improves the cure rate. Now, if we find tumor DNA in the bloodstream, what are we gonna do? How can we help her? We don't have any proven trials that say that if you find the tumor DNA, give the woman this treatment, and then a certain percent, you'll clear the tumor DNA out of there and you'll save their life. You'll cure them of the breast cancer. We don't know what to do with the information. That's one problem. The other problem is being clear does not guarantee at all that there's not cancer in the body. I mean, it reduces the risk a lot that there's cancer. It reduces the chances that there's cancer in the body, but it's by no means a guarantee. So this slide here tells you why we're not using it every day in the clinic, but you can tell how powerful it could be if we really had an accurate test. So there are many trials going on right now trying to figure this out. If you find the tumor DNA in a woman who's already had all the standard treatment for breast cancer, if you find it nonetheless, then in these particular trials here over on the far right, ctDNA positive, if you find it, then the women are randomized in the clinical trials. The computer flips the coin. Half of them stay on the anti-estrogen therapy that they're on, and half of them switch over to get these drugs called palbociclib or ribociclib. That's Ibrance and Kisqali. These are the CDK4/6 inhibitor pills that can stop the cell division and kill the cancer cells. And so these trials, specifically in women who we find the tumor DNA in the bloodstream, they're giving them these important drugs, the Ibrance and the Kisqali, to see if they can clear the blood of the tumor DNA and prevent that metastasis. So there's a whole bunch of trials going on trying to tell us what we're supposed to do. How can we help women? How can we save lives if we find the tumor DNA? So many trials are underway testing women who we find mutations in their bloodstream, giving them novel therapies, brand new therapies, targeting the mutations in their bloodstream. But we need to know down the bottom what therapies are effective, what will work to clear the tumor DNA out of that woman's body. What are the mutations in her breast cancer that we can go after with therapies to clear the tumor DNA out of her body? So I wanted to share with you then a trial that I'm going to be opening here at Baylor, where I work in Dallas, here over the next, I hope, couple of weeks. And Bodur very kindly said that she would put an announcement on the Bench with Bedside website to announce when this trial opens, because some of you may be interested yourselves, or you may have friends or family member that this would be appropriate for. Now, this is called the TRIM trial, and it stands for adjuvant tirzepatide. What's tirzepatide? Tirzepatide is Mounjaro. It's the Zepbound. It's one of the new drugs that you take as a shot under the skin once a week to cause substantial weight loss in women who are very overweight or obese. And this is to give women with node positive breast cancer. So they had lymph nodes positive, and they've already had their chemotherapy. They're on their anti-estrogen therapy. They're clear of breast cancer as far as we know. And then we're going to monitor these women's blood to see if they have tumor DNA. And if we find tumor DNA in the bloodstream and they're overweight or obese, we're going to treat the women with the tirzepatide, which is the Mounjaro, otherwise known as Zepbound. And we're going to try to cause a lot of weight loss over 6 months, 10 to 20% of body weight loss. And we're asking the question whether a substantial reduction in weight, like a lot of weight loss, 10 to 20% of body weight down, whether that is a therapy for the women, a therapy that will lead to the clearance of the tumor DNA. So it stands for the TRIM EBC, early breast cancer trial. I'm going to go kind of quickly here just to make a point on each slide, but for time, I want to leave time for questions. This slide just tells us that if a person, a man or a woman shown here, has any kind of cancer, you see all these cancers there, any kind of cancer, and they have obesity as well, that their risk of dying of that cancer, having a metastasis from that cancer, is higher because they're obese compared to being non-obese. We know that increases the risk of recurrence. And what this shows us here, very importantly, is let's just look, for example, on the bottom right curve. If women are overweight or obese at the time of a breast cancer diagnosis, and then they gain substantial weight, 10% or more of body weight after that breast cancer diagnosis, you can see on the far right on the bottom, the black dots, and then there's the line above and below it. That tells us it's elevated above the horizontal line. That means that there's an elevated risk of cancer recurrence. We know that a 10% or more weight gain after a diagnosis of breast cancer increases the risk of recurrence. So something about that weight gain, putting on more adipose tissue, makes that breast cancer more risky, a bit more aggressive. And this shows here over on the right, up at the top, it is fat, subcutaneous fat, adipose tissue. Down the bottom right, visceral fat. That's the fat inside our abdominal cavity, that if a woman in the blue lines, if she doesn't have very much fat subcutaneously underneath the skin, so that's the fat on the outside of our body, or much fat on the inside of her body, then her percentage survival chance is higher, shown there, than the orange line if she does have considerable adipose tissue on the outside of her body or on the inside of her body. You can see in the red line and the orange line, her chances of surviving the breast cancer are less. We know that being obese with breast cancer reduces the chances of doing well from the breast cancer. If you look, for example, I'll just show you panel E down the bottom there. These are women that are in the blue line on the top is lean women. And then the other two curves are on top of each other. Red is overweight and the light blue is obese. These are women who are getting chemotherapy after their surgery for breast cancer. And you can see that the lean women have a lesser chance. The curve is on top. It's a lesser chance of developing a metastasis, whereas the overweight and obese women have a greater chance. That curve is down lower. That means there's more recurrences happening. So we know that being substantially overweight or obese, our treatments don't work as well. And this just shows insulin resistance, shows us here that women who are running a lot of high blood sugars, that means that the insulin levels are higher, the body's not handling the blood sugar, and so the insulin is coming out there to try to get that blood sugar out of the bloodstream, and insulin is a growth factor for breast cancer. So we know that having a lot of insulin, which usually comes from being overweight or obese, and the sugars are not in good control, that increases the risk of dying of breast cancer. This slide just shows us that, unfortunately, during our breast cancer treatments, chemotherapy, hormonal therapy, unfortunately, a lot of our metabolic parameters, like our sugar levels, the insulin levels, weight, a lot of these things go in the wrong direction, unfortunately, with the chemotherapy and the estrogen therapy. And the yellow cells are the fat cells. And when there's a lot of fat in our body, there's a lot of inflammation in the bottom right. There's a lot of insulin that can drive and support the breast cancer growth. So the fat tissue makes a lot of molecules that can actually stimulate breast cancer and prevent it from dying off with the chemotherapy and the anti-estrogen therapy. So being substantially overweight with a body mass index, a BMI of 27 or above, or being obese is a higher risk of recurrence of breast cancer. And this is just an international agency for cancer research. It says in the underline, how can we reduce the impact of chronic obesity on cancer? This is a message now. It's really a very clear call to action message. We've got to address the obesity problem in order to improve the outcome from breast cancer. We can do that with caloric restriction. We can do that with bariatric surgery. And over on the right, we can do it with the new Ozempic and the new Mounjaros, Zepbound, to help with weight loss. So I'm just going to tell you here that if a woman has bariatric surgery and she loses 25% of her body weight, then it reduces the risk of dying of a whole bunch of different cancers, not just breast cancer. So we know that bariatric surgery, substantial weight loss, reduces the risk of, reduces the risk of developing the cancer, not of dying of it. It reduces the risk of getting the breast cancer. We also know that exercise, shown here, reduces the risk of cancer recurrence. This slide just summarizes many trials here that show that exercises improves the outcome, reduces the risk of death from breast cancer. So we know that that's the case. And we know that in the red box there, that substantial weight loss, 10% of body weight loss or more, reduces the risk of developing breast cancer. But we don't actually know right now. If a woman's overweight or obese and she's diagnosed with breast cancer and she loses 10% of body weight and she keeps it off, it's sustained, okay? It's sustained. We actually don't know whether for sure that decreases her risk of breast cancer recurrence. We know that if she gains the weight, then it increases the risk of recurrence, but we don't know for sure if she loses the weight that it reduces the risk of breast cancer. And there's a trial going on called the Be Well trial, where over in the bottom right, in the navy blue boxes, this is a very, very intensive dietary clinical trial where women are given intensive counseling about how to change their diet, how to exercise, and they got early breast cancer to lose weight. And the goal was to lose 10% of body weight. And you can see that in the women who were getting the intensive counseling and exercise, that they had a 4.8% body weight loss. So that's about 5% of body weight. That's very, very good, way better than nothing. But we're not sure that diet and exercise are going to be enough, because we believe you got to get to 10% or more body weight. And so we're very excited. This compound over on the left, this is the Zepbound, and Ozempic is very similar, of course. Zepbound and Ozempic, it causes substantial weight loss. Over on the right, you can see that over a 6-month period. You can see the navy blue line over on the far right with the tirzepatide, that's the Zepbound, at 15 milligrams, that the women lost 20% of their body weight. When they got the 10 milligrams of the Zepbound, they lost 19% of body weight. And when they got the tirzepatide, the Zepbound 5 milligrams once a week, a shot under the skin, that they lost 15% of body weight. So these are amazingly effective drugs to really cause a lot of weight loss. So in our TRIM trial, we're asking the question down the bottom there, can the Zepbound induced weight loss lead to clearance of ctDNA, clear that tumor DNA out of the body in high-risk women, have node-positive breast cancer, they're on their anti-estrogen pill, we find they've got tumor DNA in the bloodstream, we treat them with the Zepbound, we get rid of a lot of weight, we get rid of 10% or more body weight. Will that lead to the body clearing that tumor DNA? Will it get rid of it? Now, this is in the animal models. If the animals that have breast cancer, the mice, are treated with the Zepbound, actually up on the top, there's a, it works for them to lose weight, and it actually is favorable. It actually slows down the progression of the breast cancer. So just for the sake of time, I'm going to show you that we're using a very, very sensitive tumor DNA assay. It's called the Haystack assay. It's just brand new come to the market, and it's very sensitive. It's more sensitive than the Signatera test in terms of trying to find that tumor DNA. So we're hopeful it'll be better. It'll be finding more women with the tumor DNA. And so what we're doing is women who had nodes positive to start off with, they're on their anti-estrogen medicine. We're monitoring them every 3 months to find tumor DNA in the body, hoping we never find it. But if we find it, then there's no randomization. Everybody gets the Zepbound. Everybody gets it. And then we continue to monitor the tumor DNA. And we are hoping that the substantial weight loss that's going to happen with that Zepbound is going to clear the tumor DNA. So we're very, very excited about this clinical trial that's going to be starting very soon. So the goal is to clear the tumor DNA, or at least reduce the level of the tumor DNA with substantial weight loss, and finding out whether a 10 to 20% reduction in the in body weight, and these are for women with a BMI of 27 or above, so substantially overweight or obese, can we clear the DNA out of that bloodstream, because we really feel confident that's going to reduce the risk of metastasis if we can clear that tumor DNA. I just wanted to end by showing you a picture here of the tumor DNA methodology that Baylor and her laboratory have basically invented. It's a very, very, very sensitive way of looking for tumor DNA, but not just plain tumor DNA. It's methylated that have these other molecules on top of, called methyl groups on top of the tumor DNA, because you can really distinguish which is normal DNA and what is tumor DNA a lot better by looking for tumor DNA that has certain patterns of these methyl groups. The cancer DNA has very specific patterns of how these methyl groups are on the DNA compared to normal DNA. So, and Baylor has evidence over on the right. These are early breast cancer patients, and this is the chances of them staying cancer-free. And on the top blue line, these are women, the blood test with her methylated DNA assay. It's negative, negative, negative. She's not finding it in these women. None of them have had a recurrence. You can see that blue line. None of them have had a recurrence. But in the pink line, if Baylor and her colleagues found the tumor DNA that's methylated in the bloodstream, there was a high chance of the cancer recurring. So this is very encouraging that with this particular test, that staying without the DNA in the bloodstream the methylated DNA that the women are doing very, very well. So this is very, very encouraging because it looks like it's very, very sensitive. So for the sake of time, I want to finish by telling you about a patient of mine, a 78-year-old woman who was diagnosed with triple negative breast cancer, grade 3, which means fast growing. She had lymph nodes in the axilla. You could feel the lymph nodes, and PET scan, unfortunately, showed lung metastasis, and they were biopsied. And in fact, she had lung metastasis. So she got chemotherapy and the immune therapy called Keytruda. And after 4 cycles of the treatment, her PET scan showed disappearance of the tumor nodules. So this was very good. The chemo and the Keytruda had really, made the PET scan go to normal in her lungs. And so she went to mastectomy. There was no cancer found in the breast or the lymph nodes. So the chemo and the Keytruda had cleared the cancer out of her breast and out of the lymph nodes. So then she had radiation therapy. We stopped the chemotherapy, and we just kept treating her with the immune therapy called Keytruda. And then the question is, we kept getting the PET scans. We kept getting the PET scans, and they were clear. And the question is, when can we safely stop the Keytruda? Is she cured? We didn't know. So what we did is we did use the Signatera test. And every 3 months for 2 years, we monitored her blood for tumor DNA. And we didn't find it. Over 2 years, we didn't find any tumor DNA. So we got up our courage and we stopped the Keytruda. And now she's 18 months later, and there's still no signs of cancer recurrence. So this is one of the things we can use the tumor DNA is if everybody's doing really well, maybe we could stop the hormonal therapy, for example. We could stop the immune therapy over time. So we could give less treatment over time. So that was very, very encouraging. So I'm sorry I ran a little bit over, but we have a little bit of time here for questions. So I'm happy to answer some questions. And of course, if we don't get to them all now, then I'll be happy to do some answers by email. So do we have any questions?
Thank you so much, Joyce. That was wonderful. And I've been trying to answer questions along the way in the chat. Let me just go and see if there are a couple that I think. There was one interesting question is, why doesn't anybody include HER2 positive patients? So I thought that was a great question. I thought you would want to hear that.
It is a really, really good question. And the reason is that women with early breast cancer that's HER2 positive, with today's therapy, the cure rate is very, very high. It's about 90% or higher chance of cure. And so the initial studies are focusing in the situations where we don't have those kind of good outcomes. Triple negative breast cancer, about 30% of women will suffer a recurrence of the breast cancer, even with our best therapies. And with the hormone receptor positive breast cancer that's node positive, again, about 30–40% of women will have a recurrence of the breast cancer. So the initial studies are focusing on high risk hormone receptor positive or triple negative to find the tumor DNA and then do clinical trials to treat that woman and clear that tumor DNA. Now, it's the exact same concept, though, with the HER2 positive. The question is, if you find it in the HER2 positive, like the triple negative or the hormone receptor positive, if you find it, what therapy is going to work to clear the tumor DNA? Because the woman's already had all of the best therapies we know how to give her, of course, because we're trying to cure her. But the concepts are the same for the HER2 positive. The concept here is honestly for any cancer. We're starting with breast cancer here. We're talking about it, but this concept of clearing the tumor DNA out of the body really is going to be across the board for all cancers, including HER2 positive. The reason the trials are not focusing on HER2 is because right now the therapies are so good. Not everybody's cured, of course, but about 85–90% of women are cured right now with the therapies we have.
Yeah, absolutely. And, the thing is that in the liquid tumor space, this has been, they've sorted this out already, right? Like they've been doing MRD testing. And so it's finally coming to the world of solid tumors, and it's going to be so, it's going to be a game changer.
Yes, big time. You can imagine we're going to be monitoring this every time comes into clinic. The cost is going to go down, down, down. As long as people stay clear, we're not going to have a guarantee that they don't have tumor in the body, but it's going to be a much, much less chance of recurrence. But if we see it come out, if we can catch it early enough, it's got to be very, very sensitive. It's got to be indicative that there's a tiny, tiny, tiny amount of cancer in the body that'll be highly treatable once we know what to treat it with. So it's a total game changer.
There's a question here. Why are so many med-oncs resistant to testing ctDNA like Signatera for breast cancer? Is it worth me going to a functional medicine doc who will order this test for me? I'm stage 1A, lobular, no node involvement, but concurrent LCIS finding on pathology.
Yeah, it's a very good question because my women come in, they ask me, hey, can we get this test, And here's what I say. I say, within a couple years, 3 years, 4 years, we'll be there. We're going to know. We're going to have much more sensitive tests, whether it be the mammotrace that Bodur and her colleagues have invented, whether it be other tests. There'll be others. There'll be several to choose from. Right now, the tests are not that accurate. The Signatera will miss. It'll be clear, but the woman's not clear at all. There's still a chance, as I showed you in the slides, there can still be a 20, 30% chance that the test results were wrong, that they said they were clear, but there's cancer there and the cancer will still recur. So it's just not accurate enough yet, number one. Number two, if we find it, we find tumor DNA, we do a PET scan. It's clear. Now we're super worried. There's cancer in the body someplace. What do we use for treatment? Because we've already given all the best treatments. What do? Do we use some Verzenio? Do we use some Kisqali or some Ibrance? We could, but we don't have clinical trials that tell us that that's going to actually work to clear the tumor DNA. We don't know it's going to work. Plus the fact we're giving that to everybody anyway. They're already getting it. So that's our dilemma. You see, we don't know what to do with it. But I tell my women, stay tuned. Give us 3-4 years. We'll be there. We're going to be getting it. It's going to come. It's coming quickly.
Another question is the ctDNA test worth it if it gives false positives, negatives?
False positives are terrifying. If you get a positive blood test, the woman is very, very worried. Her physicians and care team and family are super worried. We know it can't be false. It can't be false. It's got to be real. If it's positive, it's got to mean the woman's got cancer, microscopic MRD, minimal residual disease in her body, and we got to go after it with therapy. So those are terrifying. So this is good. These have got to be accurate. And I'd rather them miss a few and be negative and really be falsely negative. Really, there's cancer there. Don't give me false positives. That makes us crazy in the clinic. We're getting PET scans and PET scans and PET scans. We can't find anything. Everybody's terrified. What are we supposed to do with this information? So false positives are very, very scary.
Thank you. And let's see. I'm getting Signatera every 3 months. What should I do? I'm triple positive.
Well, I think that women, what everybody should do, including women that are being monitored with the circulating tumor DNA, is do every single thing that we know to keep that cancer from recurring in case it's there. We don't know. With the Signatera being negative, it's obviously way, way, way better than it being positive. But we know it's not a guarantee that there isn't some microscopic disease in the body, because the Signatera, that's the problem we have with the current assays, that they're not sensitive enough to be a guarantee that there's no cancer in the body. So with the triple positive, that's taking the anti-estrogen medicines, probably have already been treated with the Herceptin and the Perjeta, and then avoiding substantial weight gain, avoiding 10% or more body weight gain, which we know increases the risk of recurrence, avoiding substantial alcohol, drinking 1 or less alcohol drinks a day, and then walking, exercising, brisk walking 3 hours or more a week reduces the risk of recurrence. So doing every single thing we know to keep the cancer from recurring, but a clear Signatera test is very encouraging. Over time, the longer it's clear, the better it is, right? But unfortunately, I wish it were a guarantee. It's not a guarantee. So you still have to take the anti-estrogen medicines and do all the lifestyle things that will reduce the risk of recurrence.
Joyce, I have a question actually. Is it gaining weight or is it being overweight when you're treated and diagnosed,
Both.
or is it's both?
Both.
Okay.
It's being overweight or obese, BMI 27 or above, being overweight or obese at diagnosis. Our therapies don't work quite as well. We know the outcome is worse, but gaining 10% or more body weight clearly increases the risk of recurrence. Now, so many of us do that. So many women do gain weight. But what we don't know, and the trials are really, I'm very hopeful that reducing weight by 10% or more and keeping it off will improve the outcome, will reduce the chances of recurrence. I'm very hopeful that'll be the case, that hope is not lost. If you're overweight or obese or you've gained the weight, I'm so hopeful that taking that weight off and keeping it off. That's why I'm so happy we've got the Ozempics and the Zepbounds right now to help us in the clinic.
And a question, I've never had a PET scan, just a CT scan. Is that something I should insist on? What is the benefit of one or the other? I heard someone from San Antonio Breast Cancer Symposium say they don't like the Signatera test because it's not actionable. They don't know what to do with the Signatera test. And just saying such good information here. And by the way, there's lots of thank yous all across here.
Absolutely. So here's the thing. They've done studies looking at in a woman, she's got early breast cancer. She's been treated. She's had all the therapy. If she's ER positive, she's taking her hormonal therapy. They've done studies looking to get PET scans. Actually, they haven't looked at PETs, but they've looked at CAT scans. They've looked at bone scans, and everything's clear. Then they said, well, if you pick it up early on the scans and you start the treatment as soon as you find it, do you save lives? Do women live longer? And you know what the problem is? By the time you find something on PET scan or CAT scan, and it's both the same, it's already metastasized. You've already got a frank metastasis. And we know we can't cure ladies. So they're not that helpful because we're interested in curing people. So that's why we're focusing on the blood tests, the tumor DNA, to find it before you can find it on the CAT scans and the PET scans. We don't want to find metastasis. We want these tests to be so accurate that it's telling us there's microscopic MRD in the body. And so we can treat that, and hopefully the treatments are going to be good enough to get rid of that. That's the issue. So the CAT scans and the PET scans don't help us in the clinic, because by the time you find something on one of those, it's too late. The woman has metastatic disease.
Right. And, the answer, there's a question here. Can analysis of ctDNA tell you which organ the breast cancers are in? I guess that's the next generation, right?
Yeah, that Bethesda is working on that next. She's going to tell us not only that it's there, she's going to tell us how to treat it. What are the mutations? What should we go after? And then she's going to tell us where it is. Going to tell us all that by her methylated patterns.
Exactly.
Unfortunately, I'm going to have to run. I got to go catch a flight, everybody. Thank you guys so much. I hope this has been helpful. And Bethesda, big hug, big hug.
Thank you so much, Joyce. Thank you.
Bye.
Bye. I'm happy to take a few questions if people have some additional questions. And thank you again. This was a really special presentation today. Dr. Shaughnessy, as you know, is absolutely an amazing person and physician and scientist. So thank you for staying. These slides and the presentation will be available to you online in the next week or so. Sometimes it takes us a couple of weeks, but yeah, they'll get up there. You can go back and watch them, and they'll be available for others who could not make it. Does anybody have any additional questions for me that I can answer? Hi, Lisa, I see your hand there waving. Wait, you're on mute. You're on mute.
Thanks. I don't know if you remember, but a couple of webinars ago, I emailed you what I think was the circulating tumor blood test that I had done.
Did I?
Do you remember if?
Let's see. Did you email me my USC email?
It went to the study account. I'll forward it to you. Yeah, we got it.
Oh,
Thanks,
okay.
Lisa.
You got it? Okay.
Was that, is that what that was?
Audrey, do you want to send me the email? I could take a look at it and I'll just forward it to my USC. Let me just take a look at it while we're taking other questions and I'll respond. Any other questions or comments? We have Alex Kelfa here in the audience today, who's a graduate student in my lab. Hi, Alex. He's actually working on the mammotrace study. He's spending a lot of time on the study. So just wanted to call out. And of course, you all know Audrey Sagayan, who's our research administrator for the breast cancer survivorship study that we're running. We are still enrolling people. Just to give everybody a quick update on that, I would imagine many of you are on the study. It's a research use only study. We can't report on the findings. For those of you who are on the study, we're actually running the mammotrace test on your samples. We just can't report the data back because it's research use only. But what we are doing, we've I guess about 60, it was about 80%. Now we've gotten it down to 65%, I think is the latest. White participants. We want this to be a multi-racial, multi-ethnic cohort. And so we had to slow down enrollment for women who are white, just to allow others to come in. It's a little bit harder to enroll women of minority and racial backgrounds and different racial backgrounds, non-white racial backgrounds, because white is a race as well. So we just wanted the opportunity to be able to work a little bit on getting some of these other women and underrepresented minorities in our study. But we will adjust and open it up as needed. Kristen, yes, you have a question.
Hi.
Hi.
So this is in relation to the study, but not specifically to this exact topic, other than I've been having problems with getting my blood draws done at Quest Diagnostics. They seem to have issues with the paperwork and things.
Yeah, I mean, Audrey, do you want to comment on that? Yes, I apologize for that. They haven't always been, and it's so Quest specific and probably phlebotomist specific. It's so hard to control. We've actually written in many times. We've complained many times. We've had them fix problems, but unfortunately it seems like it's going to still happen. But Audrey, do you want to comment?
Yeah. Hi, Kristen. How are you? I'll give you a call on Monday, and it's much easier for me to report site-specific incidences to Quest. And then that way our leadership contact that we deal with, they reach out to those specific sites and retrain the individuals at that location. And so over the last 2 years since we've been doing this, I've just kept doing that every time there's an issue, and they have decreased. The problems have gone. Of course, they still do happen. So just let me know. I'll give you a call and we can talk through what might have happened.
Hey, thanks. I appreciate that.
Yeah, of course. Sorry for that.
No, it happens.
Yeah, thank
Yeah.
you for your patience, and to everybody for your patience and sort of like persistence on getting it done. Yeah, we've been making really great progress. We're actually about to submit our first paper from sort of like the foundational study, on the results. And you saw a couple of one of the figures that's gonna be part of that paper. Yes, our specific study is USC, North Comprehensive Cancer Center. Lisa, so I saw that you have done the Guardant Reveal. Do you want me to talk about it here? Do you want me to just say what it means?
That's fine.
Yeah, it says that your ctDNA is not detected.
Yeah, no, that's what my doctor told me, that it was clear. But so that is the same, that's the test.
Yes, it is a minimal residual disease test and recurrence monitoring test that they have. So Dr. O'Shaughnessy mentioned it briefly, the Guardant Reveal test, because there are a couple. So there's the there's Signatera was the first Then there's Guardant Reveal. There's also a Personalis test. You didn't actually mention that. And then there's yeah, did I say, and the Guardant Reveal. Those are sort of some of the main ones on the market right now.
Okay. Okay, thank you.
Yeah, so it's definitely good news that it's not detected.
Yeah, actually, I have another question. I did the anastrozole for 5 years. I'm been off that for a year. The one that she was talking about today, the one with the V, I don't remember the name of it. Is that something that some people do as a continuation, or what, or an instead of, or?
Yeah, I guess it's just a newer class of drugs. And so it's not, it may not be like that widely known yet, but it sounds like she could use it, and this is a question more for her, but it sounded like she could use it sort of alone. Like you don't need to use it with something else. But don't take my word on that. Well, I can, if you guys have questions that you want her to answer that are more clinical and treatment related, send them to Audrey. Audrey, if I can ping you on this, and we'll just collate a list of additional questions that you might have, and we'll send them to her, and hopefully we can get her to answer them for her. And we'll just share all of the questions and all of the answers with the whole group. Any additional questions from anybody? Yeah, I just want to thank everybody for coming together this morning, always on a Saturday, and stay tuned for November. The only tricky thing about November is I guess the last Saturday is Thanksgiving weekend. Just kind of curious what your thoughts are. Is that is that not a good weekend maybe for a webinar? Do you guys have any comments, just suggestions? Because maybe we should shift it. I'm thinking maybe we can do it the week after, because also December, and we'll just kind of combine November, December, and we'll just have one more webinar for the end of the year. So we'll aim to do it like the week after Thanksgiving. I think that's probably a better bet. And then we won't have another one in December. And then we'll see you again in January after that. But stay tuned for our next webinar. It'll be, and if anybody has topics that they're interested in, you can sort of kind of quickly jot them down in the chat. If you want to hear a repeat of something, if you want another med-onc to come in, a rad-onc to come in, just jot them down in the chat right now. And then also, or email us, just email us your thoughts. Yeah, otherwise we'll just aim for that first week of December, and then it'll be the last one for the year. Excellent. Okay, well, thank you all. Have a wonderful rest of your Saturday and weekend. And I guess that means that I should say happy Halloween and happy Thanksgiving. Since I won't see you until after. And again, we all appreciate all of you and your participation and support. Thank you so much, everybody. Have a good day.
You too.
Thank you.
Bye.
You.